Alrighty. So now that we're recording, I'm going to show what we're going to start talking about. Very easy read, Ken Blanchard's Raving Fans. The concept of this book is the fact that we are more likely to send a postcard to an angry patient than we are a patient who loves us. In other words, we're more likely to give energy and attention to that asshole patient, the patient that's not happy with whatever we did that day. But the point of Raving Fans is to capitalize on the energy that's created by people who are likely to put in positive energy into the universe on your behalf. In other words, share with several friends that you're the best dentist in town, your staff is the best staff in town, so on and so forth. For those who have ever read Malcolm Gladwell's Outliers, Tipping Point, Tipping Point, he talks about the fact that there's certain constituents of when something becomes accepted within a demographic. He talks about fads and things like that. He talks about mavens. Mavens are influential people who are likely to push something over the edge to become popular, whether it's a pair of shoes, a musical style, a word, so on and so forth. Well, a maven in Tipping Point is essentially the same thing as the raving fan. So Zach and I were talking about this recently, and I thought I would bring this book up on NECADE to emphasize the fact that there is no better free advertisement than really putting some energy into that person that comes in and gives you cookies all the time because they love you. It's easy to receive the cookies and give them a thank you. But if you can somehow feed into their ego, we all have that ego, it's likely to pay dividends over the long run. So those are the kinds of people that you want to put energy and emphasis into. And that is the concept of a raving fan. Does anybody have any insight on this? Mr. Mark Trubance.
Sorry, I had to figure out the unmute button again.
Sure.
We did that at the office here in Wisconsin, where when you focus on it and you brought it up and targeted it for the month, it was fantastic. Where whenever a patient had a great experience or said thank you, the first thing we would go back with is, you know what, I'm so glad that was, a great experience for you. We love working on people like yourself. If you know anyone else that could benefit from our services, please pass along my card. Make sure that you tell them or that we know that you sent them our way. But more for targeting patient referrals from those patients who you'd want to fill up your schedule. And yes, especially if that patient is like having a good experience right now, they're super happy, super thankful, that's the best time to ask for a referral from another patient.
Yeah.
Which all we did for every couple months, we'd kind of trail off and forget. So we just did that in our morning huddles as the end of the reminder. Hey, make sure to look for a referral today. See if there's someone. But that's when we would have consistent new patients that were quality, is whenever we did that. And it doesn't take much.
It doesn't take much, but isn't it easy to let it go by the wayside? I mean, it takes diligence for sure.
Yeah, I mean, because we'd do great for the month, and then we'd stop doing it in the morning meetings, and it trails off, and we stop, and then you just have to remind it again. So, yeah, best advertising.
That's it. Very good. Thank you, Mark. All right, so I'm going to go ahead and share my screen. Mark, can you just give me a verbal confirmation that you can see this okay?
I'll let you know when I see it.
And that's why I did it. There's so many buttons to press. I was talking to somebody recently about a program that can be used for this kind of platform where there's several screens on my end. And I took a look at the demo.
I can see it now.
All right. Let's just say it was a little complicated for my style. All right. Nice fancy blue/purple screen here. We good, Mark?
We're good. I can see it.
Thank you. All right. So this was the patient that I wanted to talk about today. This is a very typical patient that we see in our practice day in and day out. Patient who had some sort of significant dentistry probably 10, 15 years ago, and in their mindset probably was the last time they were ever going to see the dentist. Of course, they show up presenting like this, and of course we see some issues going on. So what I wanted to do, I want to talk about this treatment plan. The title was The Cost Conscious Patient. So I'm kind of giving away the ending, which is okay. We're going to treatment plan this as if we don't have that financial limitation. But just keep in the back of your mind that we're going to ultimately see what I did and how it came out years later. This was a case I had done back in, not this particular photo, this is how she presented, but the rehab that I had done back in 2016. So let's take a step forward, look at her pan. Fully edentulous on the upper arch. She had been without those upper teeth for decades, not years. She was happy with her existing denture. As many patients sometimes forget, the early days of having a denture eventually give way to a very comfortable appliance that, as long as they can tolerate it, they can be happy with it. Unfortunately, she was a bruxing she favored bruxing as her preferred occlusal presentation, as we saw on the image here. All right, so here are the two photos we're going to go off of. The goal here is not to treatment plan this patient. She's already been treatment planned and she's at a good spot now. But we're just going to use these two photos to develop the treatment plan to hopefully drive some points home. So here we have the problem list, and I'd like to start asking the crowd out there to identify some problems. And I'll start with missing teeth. Missing teeth is always a problem.
She has some recurrent decay. For some reason, there's a deep bite on a denture.
That's what I was thinking. Yeah, it looks like there's some sort of occlusion going on. Some sort of occlusal disharmony there.
Mark, can you comment to what you're seeing there?
I mean, we just have a single photo, but the extensive bruxism on the residual anterior dentition. Can I say collapse video? I know you get so excited when I say that, but every tooth on the opposing has evidence of damage. Maybe 27 is scot-free, but I'm going to say a collapse video.
You can never tell a collapse video based on this image. Collapse.
Did she have a lower partial?
She did not when she presented.
Okay.
Which may suggest her vertical collapse because she had no posterior support.
I mean, it just looks like the way the teeth were set, that there was something on the lower that she had first, and then they built the denture after.
Yeah, like it was opposing it from 6 and 11 distal.
Yeah, I'm just impressed that she chipped those. She must have really good suction, a good seal.
Yeah, it's been a while since I saw this case. I was astounded at that fact too. There was some degree of that's the way her teeth were when she had the denture done. So it's very possible that what we're seeing didn't happen as a result, but it happened prior to. So definitely, for a denture to look like this, there's obviously some malocclusion, destructive forces going on. So we have recurrent decay. What about where there's no teeth? Can we say bone loss? Bone loss is a common problem, so we tend to overlook it. You have to, or at least in my opinion, you have to articulate bone loss because she's less likely to be able to receive implants back here. If she didn't have bone loss, she'd be able to get implants. That wouldn't necessarily be a problem. So quantifying bone loss, and both on the lower arch and the upper arch, she has a quantification of bone issue. So that also being a problem. I'm going to add she had dental anxiety. No contributory medical issues for the sake of today's argument. From these two photos alone, I think we've got it. I think we can already start to think about some potential solutions here. But what I would say is a patient like this is going to have the old shoe problem. Zach, you want to take a stab at what that is?
Is that where she's comfortable with her existing denture and wants it like that?
Yeah. Nothing fits like the old denture. So anytime I see a patient that's had a denture like this for a long time, especially one who has been functioning on the anterior, there is a lot of muscle coordination that went on over a very long period of time for that patient to be able to chew. As a result, where the next denture is going to go is not only going to fit differently, but in three-dimensional space, these are very difficult to replicate because this patient didn't function with posterior support for quite some time. So when you see this, this presentation, at least in my experience, and I've had wise denturists in my circles confirm this, that these are sometimes the hardest patients to treat. So setting the expectation with the patient that you do need a new denture, but it's not going to feel like your old denture for quite some time. All right, so I think we've identified most of the problems here. Let's come up with 4 strategies. I call them solutions here. The way I like to treatment plan is I come up with 4 strategies. The first one is typically removable. The second is crown and bridge. The third is ortho, crown and bridge, and maybe some implants. And then the fourth is either an all-on-4 or the most expensive full mouth rehab you can think of. They come in many different flavors and varieties. But let's start with, what is this patient's most cost-conscious option here?
It'll be removable. It's the upper into a lower partial.
Yep. So upper complete denture, and then lower RPD. And then 1A can be keep teeth as they are. 1B can be resin to create new lower aesthetics and bite plane. 1C, crown lower 6 teeth. And then 1D, ERA attachment RPD. All right, so that would be strategy 1. Patient comes in, $5,000 is a lot of money. It would probably be something in this arena here. So the removable solution. Anybody have any comments? We're going to come back to this. Anybody have any comments about removable being the strategy? All right, what would be strategy number 2? Our goal here is to come up with 4 strategies for this patient. To do a combination case. So we're using implants and removable. The term combination comes out of the world of prosthodontics. Combination, combining implants and removable to solve a problem. So we could have 2A, which would be 2 implants distal to the current lower teeth, distal to lower 6 anteriors. 2B, 2 implant supported bridges in the posterior. So essentially that would involve maybe 1 implant here, 1 implant there, and then a 3 to 4 unit bridge that would be sitting on implants, and you would have 2 of those. We're starting to go up more in cost. Strategy 2, implants and removable. So upper, locator, complete denture, and 2B. Obviously, there's lots of ways for us to slice and dice this. These are just ideas. Anybody else have any ideas when it comes to using implants and removable here? All right, let's go to strategy number 3. I'll give you a hint. The strategy number 4 will be upper and lower all on 4s. So this would be, go ahead.
You upper complete, and then are you talking lower, remove the remaining teeth to implants?
Yes.
Denture.
So 3A could be an upper complete denture and a lower all on X. 3B could be upper all on X and lower ERA attachment RPD. That would be pretty fancy. And then 4th would just be upper, lower, all on 4. All right, so you present these ballpark options to the patients, and she says, I only have $5,000. Upper and lower, all on X. I think we've talked about the idea of an ERA attachment RPD. Let's go to a picture of that. This is an old style partial that used to be used very commonly in the world of prosthodontics, where you would have these attachments extra coronal, because they're outside the crown, as opposed to an intracoronal where the attachment's on the inside. Extra coronal attachments kind of won the war between extra and intracoronal situations. The lab would make this crown with some sort of female component, which there would be a male nylon sleeve very similar to a locator overdenture, and it would snap into place. It looks like here they probably did a root canal in a tooth, and then they placed a locator styled tooth-borne overdenture abutment. So essentially the partial snapped on this, and this. These are essentially ERA styled over partials. Anybody have any questions about this? Has anybody ever done them, and do they work? I've done 3. One of them was a redo case where the patient had decay underneath 23 through 27, something like this here. She didn't take care of her teeth, so what I did only lasted 3 years. The other 2 patients unfortunately passed several years after we did it, and for all I know, it worked. I had seen them, I think I saw one patient 5 years after and another maybe 7 or 8 years. But these were patients that took very good care of their teeth. With that said, in the age of implants, this is a very complex treatment plan. It's very difficult to get a partial to fit very well around the teeth and on these locators. They're very difficult to clean. Oftentimes these lower teeth are splinted together, so the patient will have to somehow clean underneath. I will say the water pick has changed that particular aspect to hygiene for patients. I don't think I would necessarily choose a treatment option that relies them on using the water pick every day, unless they've proven that they can do that. These are blue here. This is a wax pattern. You can see the lab created these metal insets so that the partial has more positive seating onto these teeth here. But that's what we talk about when we say an ERA styled partial denture. Coming back to 2, I love the idea of placing 2 implants distal to the teeth and then having a partial snap onto those. The reason why I love that, those can eventually be used as either an all-on-4. You can repurpose those implants as long as they're healthy, or you can place 2 implants in between them after these teeth become unserviceable, and then you have 4 implants for a nice overdenture. There's a little more to the planning that kind of case because of the different bone levels. With that said, that is something that we've done in the past. And patients always like when you give them an option that keeps the door open at a future point in time. So this particular patient basically said, look, I've got about $5,000. What can we do? So we come back to strategy 1, removable. What are some pros and cons to these four solutions here? We talked about the cons of this. Let's just say that we didn't do that with this particular case. This is more about an option that the patient chose that was probably not my most favored option, but the patient ended up deciding on doing that. What are the things that we need to keep in mind if we choose these options here?
So I had a patient who basically has option 1C, and he's extremely frustrated because now he's at a point in his life where he's older, he doesn't have the resources, and he has such bad dry mouth that he can't help but get decay all the time. So he's one by one lost each crown on the lower front from canine to canine. So he's frustrated that he spent $4,400 back in the day to crown those and ended up losing them all and adding them back to his partial.
So he had a lower partial?
Yeah, he had a very same setup, canine to canine with distal, but he had all those crowned because it was originally crowns back in the day to rebuild his bite.
Sure.
And then he, within 15 years, started losing each of them just due to recurrent decay.
In hindsight, what could you have done differently?
In hindsight, it would have been better to do implants right away for him, because the dry mouth part, he could keep it clean. It's just the decay kept coming back and back and back.
Right.
Or you take out the front incisors and just have the canines, and he can focus on keeping 2 teeth clean.
Right. What if, when we do our partial design, if we have a patient like that we think there's a high risk of imminent tooth loss, communicating with the lab the major connector so that future denture teeth can be added to it, what would be what would be the decision there? We have our lingual bar, lingual plate. Was that kind of thought put in prior to?
I think for him, we had to add it. He had a lingual bar, so they had to solder metal up for each tooth as he lost them one by one.
Right.
But yeah, if lingual plate would have been nice because then you could have added it easier.
Sure. Yeah, I find when they solder to a lingual bar, it's not as strong as a lingual plate. With that said, lingual bars there's several advantages. They're more hygienic, more aesthetic, so on and so forth. But they're interesting questions to have when you do a case like this. As a young clinician, it's so hard to think that far ahead. We're so scared to do what we're doing. We just want whatever we're doing to last forever. I'm speaking for my naive, immature clinician self. I just couldn't imagine planning a case knowing that what I was going to be doing for them was going to fail. And I think that's an important concept to understand as we talk about these cases more and more. Those of us that have had these situations arise, despite the best of attempts, it's important to understand that what we put in there doesn't last forever. Not even the expense of all on fours. And that's something that the more and more that we're realizing peri-implantitis is a real thing, we have to set the expectation with these patients that this is not the last time you're going to ever see a dentist. It's just the best option you have for you right now, and if you keep it clean, you might not ever see a dentist. So drawing that same kind of rationale to partial dentures in patients like this, it's tough, because patients already hate us enough. The last thing we want to do is tell them exactly what might happen. But that's an interesting concept. I like the idea of keeping the canines. We have a transitionary plan we call the flux plan, where we keep the canines. We do something like a Q-cell denture around those canines. But I think Mark hit the nail on the head. Implants are not the answer to everything, but there's cases like this that maybe they are. I can't say whether this patient probably would have been better off with implants or without. We'll take a look at what we did moving forward. Is there anything else about these particular treatment options? What about talking about resin versus crowns? The cost difference between doing 6 interior handcrafted resin MILFDs versus 6 crowns is rather substantial. At least in my fee schedule, that's probably on the tune of $4,000 difference. Would we feel comfortable doing resin here versus PFM, zirconia, or Emacs?
I would be concerned about the history of bruxism and obvious incisal chipping that could just manifest again as soon as you place anterior restorations without considering the bruxism or possibly airway or other parafunctional habits that are going to contribute to failure of those restorations.
Yeah, I love what you just said, airway. I mean, it's very likely that this patient has all of these problems because of airway. So there's three things I see in this upper photo that suggest airway. You want to take a stab at what they are?
Macroglossia.
Yeah, macroglossia. I know what you're saying. Macroglossia would be a diagnosis of a large tongue. Microvault, making it look like macroglossia. So a small garage for the car to fit in. I can't say whether or not we've crossed into that, but macroglossia being a very specific diagnosis. But large tongue, large tongue for the space. And I apologize, I get stuck on semantics all the time. Neither here nor there. So the tongue looks like it's looking for more space. So that would be number one. Number two, obvious incisal wear. Number three is a little bit less obvious.
The erosion.
Yeah. So how does erosion play a role here?
If you're struggling to breathe and you're creating a negative pressure in your chest cavity, you're going to pull something up. And sometimes that something is stomach acid.
Yeah. Yeah, so when you see the cupping, just like we see on number 23 here, cupping only happens when there's an erosive component. Attrition is a mechanical process.
Wait, Mark, can you say that again? I really liked how you described that.
So if you're struggling to breathe, your chest is creating a negative pressure to try to pull something in. And if the airway's blocked, it's going to relieve the pressure somewhere. So it might pull from your stomach and pull it up into your mouth. So nighttime GERD is a risk, but it's also nice to tell patients too, hey, the atria in your heart is also very delicate and it'll overexpand as well if you're creating negative pressure and overfill.
Wow. Is that from Spear? Or you're trained in one?
I think I took that one at the Pankey course, but it's taught by the same faculty who teach Spear.
Oh, awesome. Thank you for sharing that.
Yeah, anytime.
Yeah, that's a good one. It's an easy...
So, I agree with Elijah, too, though. I mean, if given the patient, crowns would be better than just composite. Composite, they'd be back in your chair constantly breaking.
Yeah. Yeah, materials...
It'd be nice if you could do survey crowns, too.
Yeah. I think the more that we talk about idealizing the prosthetics with both materials and processes, I think we can get better outcomes. I love the erosive component to this. Thank you, Mark, for your explanation. Elijah, awesome for bringing up airway. I mean, it's such an overlooked thing. This patient has an airway problem. Back in 2016, when I did this case, I was not as aware about airway as I am now. It'd be interesting to follow up on the patient and see where she's at. But let's just take a look at what I did. All right. So I chose resin. This patient had $3,000, so I started with $5,000. This was at a point in time when I was looking to drum up business for our new big building that we were doing. So I was looking to do anything I could possibly do that would make patients happy. Long story short, she chose option 1B, which was resin with a new upper denture and a new wrought wire clasp lower partial. About as economic as they get. So here's my resins. We can beat these up all day long. Biomechanically and biologically, these teeth are better than they were. Obviously, I could have gone back in and redone that contact between 24 and 25. If anybody's ever done this by hand, I think you'll appreciate how difficult it is. I was using BioClear matrices, triad, wedges. As I was doing it, I thought I had full control over the outcome. Neither here nor there. This patient was looking for an economy option. Frankly, I think that's pretty good considering the fact. That's what it looks like. So this was before we did the upper denture. So to talk about the staging, I did this by hand. Then I took an impression of the lower arch, and I took her final impression for the upper, so that I did her jaw relations with these new aesthetically driven handmade composites. I say aesthetically driven. The occlusal plane was driven by the aesthetics of her lower lip. And that's what she looked like there. And then there's her final denture on the upper. What's nice about using composite, I wouldn't say what's nice. If you're going to use composite, you want to make sure that you create a height of contour so that these Rottweiler clasps can go on there and they have something to engage. We did a lot of Rottweiler clasp at my dental school. One of the instructors, I think he was 150 years old, pretty sure he invented the Rottweiler clasp, advocated for our understanding, so I was very comfortable in doing this case for this patient. She loved it. So this is a case I talk about often, in the fact that it's not always the most expensive case that's going to get the patient to the finish line. This is exactly what the patient wanted. She has posterior support. The upper denture fit fairly well, considering she had an old pair of shoes that I had to live up to. I would have loved different shaped teeth. I don't like these more round incisal, disto-incisal angles. With that said, this was a pretty good outcome considering how much money she spent on the case. So again, this was back in 2016. She came in for a hygiene exam 3 months ago, and this happened. I'm sorry, this was a year ago. But she was back in hygiene recently, which prompted me to take a closer look at this case. So circling back to what Elijah said, she's an airway patient, therefore she's more likely to brux. These are things that are likely to happen. I got very lucky in the fact that she's not the kind of patient that would get upset with me. But how many patients have we had where this happens and they literally get upset with us because they just spent more money on their teeth than they have spent on anything in their life? So one of the things we try to go over a lot in the practice is setting expectations with patients. And it's always difficult because setting expectations sometimes sounds like those commercials for some sort of medication, and there's 50,000 different side effects that might never happen. But in the dental world, I think it's important for us to cover these at some point or another, even if it's buried in a consent form that they sign last minute. However you want to resolve that is up to you. I've had lots of patients where this has happened, and I do what I think we all do. The stupid lab must be using a new glue. Well, that might be true. But at the end of the day, a denture sucks. And there's a reason why many clinicians don't even do dentures anymore, especially as the denturist becomes more and more relevant in clinical practice. Sometimes it's easier just to kick that person down the road and have them go see the denturist. Zach and I have spent some time in a local denturist clinic, and they spend half their day repairing stuff like this. It's tough to make money when all you're doing is repairing what was paid for at a pretty low cost point to begin with. So before we move on, anybody have any thoughts about this case? I chose resin. Yes, that was not the best material choice. Patient was happy with that decision. I will say that they look pretty good still, 5-6 years later. They don't look as good as they do in this photo. They're definitely worn. With that said, they've protected her teeth from further breakdown. So maybe resin's not the best material choice, but it did delay the inevitable for her. When her and I talked, we had talked about maybe 2 at a time replacing these with a stronger material. She's happy, and as long as her mouth doesn't get dry, like Mark was saying, these are patients where dry mouth invariably will come and destroy this bond layer here. So not only is resin not a good choice based on its structural integrity and its potential lack of wear resistance, but we have a bond layer here that's very susceptible to secondary decay. So I'm very cautious when I see this patient to remind her that what she had done is not the end all.
Turned out nice.
So I just wanted to go over, I have one more PowerPoint I want to go over for the last 20 minutes, but what are some terms that we can use for this kind of patient, the cost-conscious patient? I don't know where in my CE journeys I remember there being somebody who talked about this, and it was rather eye-opening for me. You want to be careful in how you phrase this patient to other providers within the practice or the front office or the assistants. You don't want to say the patient chose this because they don't have any money. I've had assistants say that, and I cringe when they do that. But getting the verbiage or the phraseology within the practice to use things more like financial constraints. Back when we had 2 doctors and 5 chairs, we spent a lot of time on this concept. It was fairly soon after that CE event that I'm referring to. But we talked a lot about financial constraints being the term that we use for patients like this. Does anybody have any additional negative phrases or positive phrases when it comes to this kind of reference?
I like financial constraints. I use that one. I use that at least documenting clinically. I use that one all the time. Why they didn't go with the root canal or whatever.
Yeah. Yeah, that's a good point, Zach. Putting it in the notes, that's not judgmental. Really, all of these are facts. I guess it's not judgmental. But in the negative phrase section, those can be inflammatory to the wrong patient. All right. Anybody have any last minute thoughts, comments on this patient here?
Yeah, I got a question. Do you warn the patient or preface this treatment saying, if you remove the denture at night appropriately, we're more likely to see those the mandibular anterior restorations last longer or be less likely to fracture?
Yeah, especially if they're a bruxer, nocturnal bruxer. I've made night guards for patients in similar scenarios. I don't think I did with her. I can't remember why. But a lower Essex that slides on. They don't wear the lower partial. They just wear the Essex, and then the upper denture slides on that. I've done economy dentures from Glidewell that they wear at night so that it wears the denture down. I guess that wouldn't necessarily protect the resin. But I think your question is more, would you advocate for the patient to leave the denture out? I advocate all patients to leave their dentures out just because it's cleaner. It's what we were taught in school. But a lot of patients wear their dentures, and I don't necessarily see an uptick in issues for patients that wear their dentures overnight as long as they clean them well at some point in the day. And I think patients inherently just do a good job of keeping their dentures clean because it's rather self-reparative, meaning when they get nasty, they're more likely to clean them well. So with her, I'm fairly sure I told her to keep it out at night. There are some patients who will overclose and they will bite into the palate. So wearing an upper denture sometimes is necessary to prevent that from happening. But I think the normal muscular posture of the tongue, living at the roof of the mouth, if the patient has proper nasal breathing, more times than not results in them not biting down. So my recommendation would be to have them not wear their upper denture unless they have to. And if they do...
So I want to do like a boil and bite mouth guard and just pop that on the lowers.
Yeah.
If they're like hitting their gum tissue.
Yep. That'd be a great idea. Yeah, anything to prevent the materials from touching, for sure. With that said, acrylic against composite. I'm not sure if there's been studies on that. There's definitely a lot of studies in the world of all-on-fours that talk about when you have an upper and lower all-on-four facing each other, what are the best material selections in a bruxer. Upper PMMA and lower zirconia was what I remembered as the ideal material against material. But I think because you have an upper denture here and it moves, you're less likely to have attrition long-term than you would if something was fixed. So material selection is always a very interesting conversation, especially in a bruxer. Yeah. All right, let's zip over to.
Just to add one more question to
Yeah,
that.
go for
Do
it,
you
man.
think, sorry to beat it to death, but do you think that the attrition present on the mandibular anteriors was present prior to this patient receiving this treatment 15 years ago,
I do
or
think
before you started working with her?
that's my recollection. This kind, a great question, and Elijah, keep them coming, man. This is what it's all about. I'm always just trying to balance that awkward silence and moving it forward. But if you have questions, feel free to interject. This particular patient looks like the kind of person that might have had a chewing habit on the front teeth, or had very significant crossover wear. It's hard for me to describe crossover wear. Mark, if you have a more eloquent way of describing crossover wear, essentially it's when.
I feel like sorry.
Let me just throw this out there and then see if you can re-articulate it. When you go into canine guidance, you're riding on the inside of the upper teeth, the upper canine, and the outside or the buccal surface of the lower canine. Once you cross the incisal tips of the canines, you're in crossover at that point. When we design occlusal schemes for full mouth rehabs, there's a very specific thing that we try to get the labs to do, and it's called crossover balancing. Well, point is that when you cross over there, the canine is no longer guiding the mandible. It's now the front teeth. And there are people, and I think she was one of them, that probably lived in this area of crossover wear. They tend to be airway patients, and their mandible is traveling a very far distance laterally, and there might be a vector of movement anteriorly. But these patients present with very significant anterior wear. So either she had an anterior parafunctional habit, such as a pencil or a pen. We've seen people who do that, or she had crossover wear. With that said, the upper denture has evidence of that crossover pattern or parafunctional pattern. So my guess would be that she presented with this prior to that upper denture, but the reason why she ended up this way continued with her upper denture. So I think it's both. Mark, do you have any different ways of describing crossover wear?
Yeah, I like it. What the usual hallmark sign, or a diamond shape in the front, where the lower incisors dip down as you go from 23 to 24 and 26 to 25,
Yep.
and the uppers also go up. No one goes there consciously, but in your sleep, you'll kick your jaw all the way out there. So I'm betting if you slid her mandible to her right, you'll see that the slope on 8 lines up quite nicely with the slope on 24 and 23.
Yep.
Because if they go on protrusive, they're not going to hit there, and your patient's going to be like, no, I don't grind my teeth. See, I can't make them touch. And then if you slide their jaw all the way over, it's this nice little wear pattern. So it's a good way to rule out if there's bruxism.
Yeah.
Or to check if that's what the cause was, or are they just biting on pen caps? And
Right. Or both. All of the above. Yeah. Good stuff. Yeah, crossover, super interesting concept for those who are in the practice. You all have access to Spear online modules. There's several on that. It's an interesting academic concept, unless you're doing full mouth rehabs, or if you're doing interior work. You really want to know what if the patient goes into that point where their canines are crossing over, what happens. 9 times out of 10, you'll have like a chip. Let's just say you did 6 veneers on the upper front teeth and you didn't account for crossover wear. Patient comes in with a chip in the front, and then you do a new veneer and they come back with another chip. This goes on and on and on. A lot of times you can actually, after that first chip, put it on an articulator, go in a crossover, and if they fall right into that space, you know exactly what happened. So you don't do another veneer, you do another veneer and potentially redo the whole case, do another canine to improve the crossover wear, or the crossover, not crossover wear, but the crossover factor. So these are important concepts to know, I think, really for every restorative dentist. All right. I have one more concept to go over. Yeah, we have time. All right. So the Buxton Buildup. This is a concept that I don't believe exists in dentistry in the form that we're going to discuss it. At the same time, it's nothing novel. I think you guys will get a sense of what I'm talking about here. So some provocations. Should your restoration last forever? Or should the tooth substance underneath your restoration last forever? I think we'll all agree it's more the tooth substance underneath. So what this is saying is, this came from Pascal Monnier. Pascal Monnier is a world-famous biomimetic and aesthetic dentist who has done a lot of work on materials and how those materials meet the teeth underneath. And this particular thought provocation for me, when I saw him speak 10 years ago, helped me create my version of what I call the Buxton Buildup. Again, I don't think it's as novel as I'm pretending it might be. But what is the most biomimetic material? It's an interesting thought. And lastly, are old conventions sometimes wrong? Is the PFM or the gold crown really the best thing for a tooth? Maybe composite is the answer. Hint, hint. If you had a tungsten rectangular box, like you see here, would you want to put it on this table, or would you want to put it on a table that only had one leg? I think that's pretty simple thought experiment. Force distribution is proportional to the surface area that's between the supports. So the wider you go here, the more force distribution. I remember somebody once describing occlusion, saying something to the effect of the stiletto heel. Do you want to be kicked by a lady with a stiletto heel or an old man with a shoe? There's more surface area to a shoe. When you can develop occlusions, try to balance the forces with as much surface area as possible. So here came the idea of the Buxton Buildup. So this particular set of slides here is the best set of slides that I can find that describes this particular concept. Where this idea came from for me was something that came out of the Canadian Dental Journal, their version of JADA, so the journal of JCDA. I don't know how I got my hands on it. I was reading it once and they came up with the idea of doing an onlay. That's where this image came from. An onlay of Emax that also had an internal, basically replacing the pulpal chamber with an internal core. Nothing earth-shattering. CEREC docs have been doing this for years. So I was like, that's an interesting concept. What can we do with that? So here I have Pascal Monnier talking about material selection, and that old conventions sometimes are wrong. He actually made the point that crowns, posterior crowns, regardless of the material, is more detrimental to a posterior tooth than a composite onlay. So it was a series of these concepts that all kind of came to fruition one day, and I was doing a root canal, and I looked at the image, and this was the image I looked at because I saved it. I remember just thinking to myself, what if the patient bites down right here? That tooth is toast. You know, there was a lot of decay here. This wasn't because my accesses are the size of the Grand Canyon, although I do advocate for proper accesses. I don't think being conservative with accesses gets us anywhere. I think this concept allows us to avoid the unintended consequence of having a fractured tooth as a result of having something like this, a freestanding part of the tooth that is essentially left susceptible to fracture. It's this concept which I don't know why endodontists are still using cotton and Cavid, because cotton and Cavid don't reinforce the tooth, and the patient is sent back to the restorative dentist who's booking out 3 months, and that patient's chewing on that exposed tooth for a period of time. At least use something like Fuji or composite if you're going to quote unquote fill the hole. But what I advocate for is something we call the Buxton Buildup, which is before you even do the endo, you do the first step of the crown prep. So if we start with the end in mind using a concept out of implant dentistry, why wouldn't the first step of an endo access not be reduce your 1.5 or 2 millimeters of the occlusal table? Well, if you think about it, that's actually a really good idea because it gives you a flat surface to get your working lengths if you're doing the endo. You have a larger and more visible pulp chamber to see inside while doing the endo. More light is allowed in. But the best part about it is it sets you up for this Buxton buildup concept where once you're done, you're going to place a material that covers or veneers the entire occlusal surface of the tooth so that you don't end up with this. By the way, lateral canals, gotta love it. This is where the infection was. We're able to get that. That's not because I'm special at endo, it's because we use something called the endo activator. Using proper tools and using the EDTA bleach alternating pattern is what allowed that to happen. So that's what we're trying to avoid, is that fracture. So here's a very, very poor artistic representation of what we're trying to do. If we put an entire occlusal onlay, when the patient, or if the patient bites in this particular spot, the forces are going to be distributed amongst all of the teeth, or the entire surface area of the tooth. The patient bites here, all of the forces right here, we're likely to have some sort of fracture, and 9 times out of 10 it's a vertical root fracture that we see a year or two later after we crown the tooth. We've all had those patients. They have the best endo done by the best endodontist in town. They see us a month or two later, and a year or two later they have a vertical root fracture. I would beckon to think a lot of that has to do with that interim period. Maybe that fracture was always there and it wasn't picked up on the microscope. Maybe it wasn't big, I don't know. But I do think a lot of times it comes down to the fact that during that interim period, these kinds of things happen. So this is a case that I had done using the Buxton buildup concept. So this is the tooth before treatment. Here's our erosive component we were just talking about. This is obviously a patient with some sort of erosive problem. If I just did the endo here and then brought the patient back at some point down the road, the odds of them fracturing this right here is pretty high. So what I did a 2 millimeter reduction before I started the endo. I have a nice 360 degree rim of enamel to bond onto. There's my endo access. I'm not sure what I have here, if that's biodentin or Teflon. But all I did after I was done the endo, I put on a Toffelmeyer, and there's my restoration. You can see the composite onlay here. There's the line. Yes, we can talk about all kinds of imperfections here, but the point is that this tooth is not likely to break in between the appointment that I'm going to prep the tooth for the crown. One might argue that this is actually a pretty good outcome and the patient doesn't need a crown. That's not the topic of today's conversation, but I will share with you a world-famous dentist named Pascal Monnier would say this is the best restoration for this patient. This is a bruxing patient. Look at all the craze lines in that tooth. I'm pretty sure that if I didn't do this for this patient, that I'm not even sure what the gender was, he or she probably would have ended up having some sort of issue down the road had the crown not been done shortly thereafter. So there we are. And that's all we got. Any thoughts or questions about the Buxton buildup? Has anybody seen this concept in direct relation to endo? So doing it at the same time as the endo.
I haven't seen that, but it would make the endo easier.
Yeah. Yeah, Zach, I think you've done several of these. Do you find that your endo accesses are easier when you're doing this reduction?
Absolutely.
Yeah.
It really is a time saver for access.
Yeah.
And especially if, when you go to do the crown prep again, time saving. It's better for the patient. They're out of occlusion,
I agree. I think it's been a huge help. Nick, so when you do the Buxton buildup, do you leave the tooth out of occlusion with that?
I don't. It's a good question. I don't think it's bad if you put it in occlusion. For those who have done this, it's really hard to get occlusion. So I tend to leave it out of occlusion only because if I try to get occlusion, it's extremely difficult. It takes 20, 30 minutes sometimes to get that dot right where you want it when you're doing it by hand. when a lab technician makes a crown, they have it in our articulator. They have several different things that we don't have intraorally. So if I knew that this was the final restoration, would I spend that kind of time? Maybe. But I don't think this is an advocation necessarily, despite the fact Pascal Monier's work is pretty convincing. I don't think I'm advocating that we change how we do dentistry in this particular capacity. I would leave it out of occlusion somewhat. This is a pretty nice outcome, considering. It's probably why I chose this case. I have many cases where they don't look this nice. They're just flat. But I just know that if a patient bites on a Jolly Rancher, they're not going to break the tooth. They're not going to have a vertical root fracture. They're more likely to break the composite than they are the tooth itself, because the forces are distributed to the tooth as a whole rather than select segments.
I mean, that's all bonded together. If you were to prep that for a crown and look at actually how much dentin is taking the force of chewing, there's not a lot.
Right.
So,
Yeah.
I mean, I even like that for a final.
Yeah,
I haven't done that as a final, but makes sense.
I mean, that's Pascal Monier's point, is that crowns were actually, he pretty much said that this is doing the same thing as a crown. I mean, kind of is. You're covering the tooth so that it doesn't split. Yeah, it's an interesting thought experiment. With that said, I wanted to bring this up in the context of when you do endo, just do your 2 millimeter occlusal reduction, give yourself more light, give yourself more visibility into the chamber, and then cover it completely. So you want to make sure that there's all of this enamel is taken advantage of. That's a really nice bond. Now, if this particular patient had a very deep class 2 situation, maybe I don't want composite being the interface down deep. Maybe a crown is a better choice there. There's a whole argument on the bonding layer. But for this particular tooth, this was great. But this is more about an advocation for its use in the short term, if you're doing endo. So, all right. Let's see if we got that in. Yeah, with 2 minutes to spare. Cool. We have 2 minutes left? Shit, let's do it. I wanted to share this concept. We've all heard the saying, there's fast, there's quality, and there's low cost. You can have two, but you can't have all three. And I don't know why that particular saying keeps showing up in my world, but I threw it on a slide, and I don't know what I'm going to do with it over time, but let's play around with it for a second. In school, we're taught to sit high in this hierarchy, so we're taught to practice dentistry up here. The cost isn't really relevant because there's so many financial assistance measures that help patients afford the high quality treatment. But in the transition to the real world, this is so much harder. So let's just take a look at, dental schools up here. Let's look right here. This is I don't know what kind of dentist this would be. High quality and fast. This is probably impossible because labs that produce high quality just aren't going to be fast. High quality and low cost. This might be a way to drum up business. This is what you do early on to try to wow your patients, but long term, you're not going to be doing anterior Empress veneers on main care patients. Just not going to happen. The patients want you down here. So you have fast and low cost. This is the direction many patients expect us to live. So where do we go? This is an idea, and I'd love to see what people think about it. What if we presented this to a patient and told them to put a dot somewhere in this matrix and say, where do you want to live? Do you want your stuff to be high quality, but it's not going to be fast and it's not going to be low cost? That's a great place to practice. That's what Spear and Pankey advocate for. It's a great place to be. Maybe somebody just wants low cost. They don't care about the quality. They don't care how fast it is. That's the dental school patient down here. Or maybe somewhere in the middle, because a lot of times dental school work is of high quality. And then your Aspens are down here. The reason why I like this, if you give a patient this and you tell them to put a dot, you then have the opportunity to have a conversation with them that's just not how it works. Or you have a data point in the future if things don't go well, you can fall back on. Well, you put here, let's just say that they put something that's closer to the fast and high quality, and they're paying off their treatment plan. All of a sudden they start saying, this is very expensive. We have a patient in our practice right now that's basically saying this is too expensive for what I'm getting. Basically, she just doesn't understand what the hell's going on. But it would be a data point in time that you could fall back on. So I just wanted to kick the tires on this. If you guys have any thoughts, whether or not this is applicable to practice, I'd be curious to see what you think. But it falls back onto that saying you can have fast, you can have quality, you can have low cost, but you can have two, but you can't have all three. On that note,
I think it's an interesting concept. Whenever you can have the patient take ownership of their choices is always good. It's something to reference back to, these are the limitations that you set.
Yeah.
Always helpful.
Yeah, patients don't
Or
know.
great, you wanted super high quality, and it's going to take a little bit of time, but if you're in it, make it great.
Yeah. Yeah, we're running into that right now with one of the higher end labs that we use, Arrowhead Dental Lab. Our full mouth cases are taking 2 months, to do a single arch. The work is amazing, second to none, at least in our arena, but it definitely requires a conversation with the patient that you're not going to get it yesterday. So anyways, if that is relevant to anybody, please share it with me. I'd love to hear. I think it's a concept that we can build upon as time goes on. But the Patriots are playing, so I will sign off for now. Have a good night, everybody. Hopefully we provided some value.
Thank you.
All right.
Thank you.
Later.
Good night.